Recording in progress. السلام عليكم. السلام عليكم ورحمة الله. أسعد الله أوقاتكم يا رب بكل خير. الحمد لله الذي علم بالقلم علم الإنسان ما لم يعلم والصلاة والسلام. Thank you very much for being with us in today's session where we are going to talk about the pressure injury. Now we are opening a new chapter in our training in the wound care, that while we are diving inside to the specifications of the type of the wound, and the good news that we will offer the discussion of today about the pressure injury that already associated with the last update that come on the international guideline for pressure injury management. And this is maybe the first time that really we can say that this is really an international guidelines. Before that, the guideline was much more specified to its own region. Even the 2019, when they call it also international guideline, they did not take the approval from the international agencies or from a different experts or from different nations. They built it based on the European pressure ulcer panel of experts, North America and Pan-Pacific, but this time even from Africa, from Southeast Asia, there were experts from Indonesia, from Philippines, Korea, China, Africa, Guinea, Nigeria, South Africa, and even some experts from Saudi Arabia also. They participate in creating and drafting the guideline and approving these recommendations, which adding a valuable importance for such evidence. Now, in this case, we are talking really about surprising results that come about the pressure injury. We are talking about here some foundations had maybe getting to be viewed in a different way, and this adding value to the evidence that we already have it or deal with it in today. Anyway, the pressure injury module is already classified in two parts, but in this part we will talk about the new updates that happen in the guideline and how this can shape or change how we are formulating our understanding for the pressure injury. So this is what we don't want to see. This is the dilemma that we already have it in the hospitals. There are challenges that faced us, that the pressure injury is a fact, and this fact can be prevented, and all pressure injury can be prevented. Maybe if we will start by saying that in 2019, there was some options or concepts called the unavoidable pressure injury. Unfortunately, some of hospitals, maybe some of the kind of the practices, misuse this concept, which now clearly stated by the guideline, there is no pressure injury cannot be avoided. And there are some adding value happen in this guideline that they recommend for the policymakers, for the accreditation bodies to deal on that. Before in the GCI, for example, the talking was about the pressure injury, wallahi, if the patient stay in the hospital more than 6 months, so this is unavoidable. If the patient was on multiple organic failure, this is unavoidable. And they excluded from the KPI. Now, the recommendation said all pressure injuries could be avoided, and we should work to reach this level of practice. So what we are going here to discuss, we will talk about the terminology and understanding of the terminologies, why the pressure ulcer now is not used. Now pressure ulcer, now it's an old-fashioned term to describe the current issues. It's a pressure injury, not a pressure ulcer. And this is the agreements internationally happen about this term. There are comprehensive cellular pathophysiology for developing the pressure ulcer. It's issues from the ischemia and reperfusion. If you check on our previous lectures, we were classifying the theories of developing pressure injury to three categories or three theories. Now this should be updated, as two of these theories, the experts were able to collect them together to find a way that these two theories, in fact, it's a one conceptual model that can explain why pressure injury happened. What are the updates happen in this guideline? Why the 2025 guideline is different than the previous guidelines? Why this is important for us here to rethink in how we will deal with the clinical practice guideline? The good news that 2025 clinical practice guideline is totally free comparing to the previous guidelines, which that at that time there were two copies, the quick reference guide and the full clinical practice guideline. Now all it will be available. There is nothing need to be paid or per case to get the full copy. All available online. You can download it as a PDF, and this is also adding more value on the international responsibilities for the pressure injury care. What are the changes happening in the evidence-based tools and how the new guideline already deal with the issues of the pressure injury in understanding the nature of evidence. Also, there should be a distinguish between pressure injury and the other skin injuries, such as a moisture lesion or incontinence-associated dermatitis, and so on. So here, let's start by the first concern. It's now pressure injury, not pressure ulcer. Until 2019, the talking was, wallahi, in North America, we are using pressure injury. And in Europe, we are using pressure ulcer. The reason for that, because of the reimbursement, because of now, pressure ulcer is an old terminology, and it creates problems more than finding solutions. So, ulcer, it means there should be a wound. That's why in many of our region hospitals, we report the pressure ulcer to the quality department in the hospital, acquired pressure ulcer, when it's already reached second stage. That means we should have a wound. So the pressure ulcer stage 1, it's epistemological way, from scientific way, it's wrong. Cannot be pressure ulcer stage 1. And that's why the convert to the new term pressure injury. The second one is that we need to have emphasizing more on the prevention. So if we will wait until second stage pressure ulcer to happen, and in this case, we are still dealing with a stage 1 pressure injury on the current term, as something we can prevent it, or dealing with the patient on the prevention strategies, not on the treatment strategies. So this reflects the clinical realities to be in a picture that the term will be in a pressure injury, and the reporting should start for pressure injury from stage 1. And this is shifting in the paradigm, and this is create a dilemma. Anyway, still the guidelines mention that there are still studies and research still reporting bed sores, while bed sores is already scientifically incorrect term. It's commonly lie term, implies of the immobility, but this doesn't present the actual fact of the pressure injury. So bed sores, pressure ulcer is not the suitable term to be described this case. It's a pressure injury. The same for the decipitous ulcer, which comes from the Latin term, but in the English context of the scientific writing, pressure injury will be used. The same for the pressure sore, which is less specific and did not explain the actual nature. It's the same of the pressure ulcer problem, pressure lesion or pressure damage. All these terms, it's old-fashioned to describe the actual changes. Now, for the current guideline here, in 2009, it started by a project of a group of experts in the Pan-Pacific area, and they try here to create a consensus among the hospitals in Japan, China, Australia, New Zealand, which is already getting developed and getting more welcomed in Europe and North America. The good news in the 2025 guideline now, it's an integrated international approved. So this is what we can sure about it. The first drafting of this guideline published in February, and the last drafting for this guideline published last month, which means all the chapters, all the sections now already getting approved from international experts from Middle East, Africa, Southeast Asia, China, Europe, North America, South America, and so on. So this is, again, that's why we are happy to say this is the first actual international approved guideline comparing to all the previous examples. So what is the pressure injury in this case? So how I will define the pressure injury? What are the methodologies that can I use it? The definition had been little bit updated to say that it's a localized damage to the skin and or underlying tissue that usually occur over a bony prominence as a result of a pressure or a pressure combination with a shear and or not friction. This is the same term was in 2019 in defining what is the pressure injury. But here they add an oin. This does not require an open wound. So now pressure injury stage 1 is a pressure injury reported and taking our rules to deal with the patients in this way, and this is include intact skin. The well-known theories in the developing pressure injury was classifying it in a simple three phases or a three level of theories to describe why the pressure injury happened. The first theory, which is the traditional ways of understanding the pressure injury, said sustained pressure, this will lead to collapsing happen in the blood vessels, which lead to death or ischemia happening in the tissues that were relying on the tissues that deliver the blood. So this capillary occlusion lead to ischemia, cellular death, and we have the pressure injury developed. This is the first theoretical, conceptual understanding for pressure injury. Anyway, this understanding had been remodified when the cellular mechanisms theory start to appear in the works of the pressure injury. They said that it's not necessarily to have a total blood block until we have the ischemia. So if this is the artery, we have it here. This is not required from the full occlusion to happen or reduced. But what's happened that the cell itself, because of the bedridden condition, it will be under pressure. And then this pressure will be reformulated and the cell relaxed. And again, another pressure come and another relax. This create weakness in the cellular level. And this weakness on the cellular level make the cell capable or ready to convert to ischemia soon. So the problem of the pressure injury, it's not only associated with the capillary refill, rather than the reformatting of the cells itself means that these cells will be much more in risk to develop the pressure injury. So this is the second theory. The third theories said about the controversial risk that will be happen in the cellular level. And I will show you here how they convert the two theories together in the new guideline. They said that this formal cellular dysfunction that will happen on the cellular level, it's associated with the shear and friction. And this is what lead to cell deformation. And the cell deformation alone can lead to tissue injury and inflammation and necrosis. So in this case, they combine the cellular theory of developing pressure injury combined with the tissue changes and tissue pressure to be also a significant explanation for how the pressure injury can be developed. And in this way, it makes for us that easy to explain the reasons for pressure injury or assuming the conceptual reasons or pathophysiology for developing a pressure injury to be it apart from these two associations. Blood occlusions also changes on the cellular and tissue level that lead for ulcer or for injury and ischemia to happen. In the same way, we understand that there are intrinsic factors that already adding more possibilities for the pressure injury or this type of ischemia developed. Age and the skin changes, immobilization, that means the pressure and the gravitational pressure will be continued. Incontinency, and we will have, inshallah, a special session on incontinence-associated dermatitis, which means the skin on that area, mainly on the sacrum, will be under higher possibilities to be direct contact with the urine and the stools, with the pressure, friction, and shear. That means higher chance for developing pressure injury. Also, the protein deficiency and albumin, and we will have, in a few minutes, more additional discussion about how the new guidelines deal or recommend the nutritional changes. Intrinsic and environmental risk factors, pressure duration, and there are a lot now of updates about the pressure duration, the repositioning, as now we will come to see, shear and friction, and the new guidelines describe it as the semi-Fowler position creates peak shear, but it will reduce the friction, as we will see now, moisture, and the type of service that we will have. Let's here start by the first evidence-based risk assessment and a lot of discussion about the actual needs for the assessment. From the guideline perspectives, there is no evidence say that we have to do the assessment. But logically, we should do the assessment because we cannot provide the care without the assessment. So this dilemma creates a kind of discussion within the new guidelines. However, on the clinical practice, still we are supporting adopting the Braden scale, and this will be deeply explained a little bit on this own main 6 components, which are sensory perception, skin moisture, activity level, mobility, nutritional status, friction, and shear. And the differentiations that added or the adding value on the Braden Q scale that will be much more specified for the pediatric bedridden patients. For the classification, there is no big changes happen. So it's still we're talking about pressure injury stage 1, but now, and they use the same numeric value for 2019. So we will write 1 and 2 and 3 by the Arabic number, not by the Latino number anymore. And the stage 1 pressure injury means that we're talking about intact skin with non-planchabic redness over the prominence. And the key feature of the stage 1, still the same, does not blench with the finger pressure. And they said that this is enough criteria for reporting the pressure injury as a stage 1 for the quality issues. Maybe it will be difficult for the darker skin, but take the type 1 error better than to wait until type 2 error. And let's make additional focus on the condition of the patient. So this is the planchability and non-planchability. For stage 2 pressure injury, still the same definition. So we're talking about partial thickness skin loss of epidermis and a part of the dermis, shallow open ulcer. And this is the reason for the conflict or the need to change while we are describing the pressure ulcer as a pressure ulcer. So from stage 2, you will start to deal with it as an ulcer. But now with the pressure injury, so you should start the treatment part of the protocol of the treatment from stage 1, not from stage 2. Stage 2 pressure injury, it may have a blister fluids filled, either this blisters ruptured or without rupture. So the skin peeling now, it's second stage pressure injury. Stage 3 pressure injury is still on the same definition. So we're talking about full thickness skin loss, derms and epidermis. It's a create like appearance with exposed subcutaneous tissue and may have undermining and tunneling. And now much focus to say that there are anatomical organs cannot have a stage 3 pressure injury, such as the ear and nose, which will jump to be in a stage 4 pressure injury. The epaulip will be on the stage 3. So any pressure injury with epaulip with irritant or floating skin wound edge, with any tunnels or undermining, whatever the terms that you are used, that means you are at minimum level on stage 3, and this cannot happen on stage 2, and this is now clear in the definition. Stage 4 pressure injury, which means that the full thickness tissue loss with the deep structures. It's complex tissue loss with the visible muscles, tone, ligament, cartilage or bone, extensive underlining tunneling, we are in stage 3 or stage 4, high risk for infection, osteomyelitis, and this will maybe in need for advanced treatment. Any ulcer that under the hidden damage that we cannot see the full thickness, it will be the unstable pressure injury. There is no changes on the definition on the unstable pressure injury. So if we are unable to know exactly to which extent the depth of the tissue, even if you are notice, now, can I say that the patient was on stage 3 and now I am seeing white color, so I am now in the DTI because of the slough? No. It will be stage 4 because what you are seeing now is muscles or dead muscles or dead bones. So any evidence that will transfer you from this level. At the same time, we are dealing with unstable pressure injury as dangerous, highly required care in this level, and that doesn't mean we are improving. Deep tissue injury, we can say that the game was already changed because the people getting confused between DTI or DTBI now, that is the name, deep tissue pressure injury, and the stage 1 pressure injury. Intact skin but deeper tissue damage underneath, it's a DTI. Hard skin now is a DTI. Purple maroon, that is DTI, or consider it as a DTI. And they say now it's DTBI, it's not a stage, it's a separate category. That's why we should add additional efforts in assessing and estimating and also assuming that we are in a bad situation while we are in the deep tissue pressure injury. There are also more focus on the new guideline about the medical device related pressure injury. Now they included in one separate chapter. So you will have one separate chapter for the medical device related pressure injury, and not included within the other types of the pressure injury. Medical device related pressure injury, it's something we should document as a part from the location of this one. So if the MDRBI or medical related pressure injury happen, we should report the location of this and the type of the device. And the reason, of course, as all of us we know, because what happened during the COVID-19, mainly in the critical care and ICU, a lot of evidences say increase in the prevalence of this type of pressure injury in 30% of from the hospital pressure injuries during the COVID. So this is adding more value. The common sources for the pressure injury in this case, it's oxygen delivery devices, ECG labels, catheters, endotracheal tubes, cervical collars, and so on. And it's need additional description in why we are dealing with it. There are clinical differentiation between the pressure injury and moisture injury. Pressure injury, the cause here, we're talking about pressure and shear. Any moisture related to moisture, for the differentiation with the heel injury. And as we say before, the heel never healed, right? So you will see in the new guideline in a full chapter to discuss only the heel pressure injury. And this is adding value to differentiate specific type of pressure injury and to make sure that we have the clinical skills that to differentiate the type of pressure injury from any other moisture lesions. Incontinence associated dermatitis patient will have skin injury from the urine or stool. This is not a pressure injury. This could be combined with a pressure injury. And this is what will take a lot of pages in the clinical guideline. What we should observe on the pressure injury, plunge test, apply pressure release, and this is to differentiate between type 1 pressure injury rather than the TTI, skin temperature, inflammation, skin texture such as edema, hardness, and pain sensation on the patients. The studies and the guideline highlight the increased cost of the treatment of the pressure injury. We're talking about now more millions already can be prevented from this diagnosis, and the cost, the lawsuits in UK, US, Europe, and so on, it's already increased. Before we will dive deep on the guideline, I also want to highlight what are the areas still need more researches and studies. And that's why this is apart from the beauty of science when we have still some unknown comments. Still the direct cell death without ischemia, how it's already happened, because the new guidelines said it's not necessarily that we will have blockage on the blood until the pressure injury happens. So even with the blood still penetrating to that tissue, pressure injury will happen. So is the cellular deformities alone able to explain this ischemia or not? And why some patients heal rapidly on the pressure injury comparing to the others on the same conditions? There is no still clear explanation for the process of a pressure injury healing. And the issues of the re-injury or reoccurrence of ulcer while the ulcer is still there. If you're already dealing with a stage 4 pressure injury and you are doing care or part, and this area, after the dressing, there are a pressure. So the pressure will happen on already existing pressure site. And that's why you will have a tunneling and another wounds happen near to the previous wounds, or you'll see in a tunnel then in this specific area. Still the scientific explanation still need more time. The optimal timing and techniques for a deep tissue assessment, and this with what we will now go to make some surprising recommendations. This is the first version of the international guideline. Again, it's now totally available. There is no hidden part, the same what was before in the previous guidelines. And this is why we are comfortable to say it's already international, at least get the international approval from different panel of expertise all over the world. So this is now the new definition or conceptual map for developing pressure injury, which they try to connect the two theories, as we say, the cell deformities and tissue deformities, until we have it. And they say that it's not only the issues of the blockage or total blockage of the blood, and even the reperfusion itself after the blockage could hurt the patient, could make more problems than what we expect. Like when the patient tissues under pressure, so the amount of blood already reduced, then directly when it's already open, the tissues on the following part will start to have oxygen hunger, and this oxygen hungry practice will increase the free radicals. So could also this be adding value to developing skin tissue ischemia. Here, the main important change in the current guideline is this screenshot. So if we already understand this screenshot, all the other parts from the guideline will be easy. They redefine their own rules and their own position. Clinical practice guideline for pressure is not Quran. It's not something 100% fixed. And we cannot go to our hospital and say, oh, I have this clinical guideline, because they mentioned that. You know, this is apart from what we support you to do, and let's see how we will transfer or change the practice. And they did not write it in the way to be in a procedural part or policy in the hospitals, rather than it will be in a referring evidence for changes in the policies or changes on the hospital protocols. The second one, they redefine the way they are dealing with the evidences. Now, unfortunately, because of a lot of reasons, we have a huge amount of publications. In the pressure injury, maybe on daily basis, even last time I even make an unmute for the Google Scholar notification for the pressure injury studies, because every day we have a new publication for a pressure injury. But not all of these evidences is valuable, because the people want to publish, and because this publication already increased, it's hard for the readers to know, is this really valid information, or there are some biases happen, or some misleading results. It's not necessarily that when you see in a p value less than 0.05, that means we are on the safe side and this is true result. That's why they changed the level of evidence. In the 2019, they were using B1 and B2 and C strength of evidence. Now they remodify it to be easy for us to deal with this evidence. As this is international guidelines, so the nations already differ in their own routine practice, policies, insurance, nature of the norm for the pressure injury prevention or management. So we will have the recommendation that supporting evidence, you will read the words recommendations. This means, if you see it in the clinical practice guideline of the pressure injury, are based on the analysis of the evidence from Tier 1 systematic review with meta-analysis. Until you will see this words written under the statement, as we are coming now to see, that means this should have Tier 1 systematic review with a meta-analysis. And two systematic review without meta-analysis, or randomized, or 3 randomized control trial. So in this way, you will have it as a recommendation. And you will see good practice statements that mean are designed to fill the gaps, because at the end, they will not be able to have good studies for all of our daily practice in the pressure injury, right? There are a lot of things that we cannot have in a good, the same what we said about the assessment. Maybe we should do assessment because this is logical. But doing the assessment, because it's already logical, that doesn't mean we have supporting. So they replace it by GBS or good practice statement. So GBS doesn't mean global positioning system for the Google while we are using to transfer, other than here it means designed to fill the gaps. That means there are evidences, there are recommendations, and this replaced what was in 2019 by B1, B2, or C strength of evidence. And they mention it clearly that on the implementation consideration. In the full clinical practice guideline and on the interactive guideline website, because now you will have it not as a one part, you will open their own websites, then you will have a lot of versions, and this is interactive for the changes could be provided. Provide additional guideline on how, when, and under what condition to implement or not implement a recommendation or a clinical practice statement. Implementation doesn't mean assignment. They mention what should be done without focusing on how or who will do these tasks, as now you will see. Let's start by the first surprising information from the nutrition in the pressure injury. Nutrition in a pressure injury prevention, this is the final. So this is how you will deal with the guideline. You will see nutrition 1, nutrition 2, nutrition 3, and so on. And you will see recommendation or good practice system. And this is the category and the certain evidence to make sure that where we are on this statement. Let's start by the good practice system of the number 1. It's good practice to conduct nutrition screening for individuals at risk for a pressure injury. Now, we will not rely only on what's on Braden. Rather than any immobilized patient, risk for a pressure injury in need for nutritional screening. So lab investigations, so actual assessment, quantitative data about the nutrition assessment, it's a GBS statement. So now let's go to the hospitals and modify our practice. Number two, it's a good practice to conduct a comprehensive nutritional assessment for individuals at risk for pressure injuries who are screened to be at risk of malnutrition. Use the findings to develop an individualized nutrition care plan. And this was missed in 2019. They say about what the patient should take, but they did not specify individualized nutrition plan. And this is supported by tier 3 evidences as a GPS. The third point, it's a good practice to encourage individuals at risk for pressure injury to consume a balanced diet that includes nutrients, dense food, and adequate hydration. And now they increase the amount of hydration for any patient in risk for pressure injury or as a part from our efforts to prevent pressure injury. Here you can see on the statement already the text of statement had been changed to be we suggest. Why? Because this is conditional recommendation. Conditional recommendation now, there are evidences, but there are some conditions while we are talking about. There are something we should take it in consideration while we are dealing with these evidences, regardless of the number of evidences. Now maybe we have 100 or 200 evidences, but there are something could be biased or missed. Let's see the statement. We suggest the nutrition supplementation be implemented for individuals at risk for pressure injury who have been identified as malnutrition or at risk of malnutrition when nutritional needs are not met by usual dietary intake. So we should have a plan. So what if this plan did not work? It's better to have additional follow-up for issues. We suggest in 5. We suggest implementing protein supplementation for individuals at risk of pressure injuries who have been identified as malnutrition or at risk malnutrition, and this is very low evidence, but still it's recommended. And number 6, we suggest that carbohydrate-based energy and nutrient supplementation should be reserved for individuals with the known malnutrition or micronutrition deficit, in addition to supplementation that meets their, and it's recommended to be done, but take it based on the practice and the circumstances that in your clinical area. The tube feeding now, it's a strong recommendation. So we recommended against tube feeding for the specific purpose of preventing pressure injuries. At the beginning, in the previous guidelines, they said, wallahi, we could go for tube feeding because this will assure us that we already provide the proper nutrition. Now the guideline with a strong recommendation, and it's still recommendations, not a GPS, that no need to insert the NG tube for the purpose of pressure injury prevention. Maybe the patient need for NG tube for other purposes, but don't make it only if the patient in risk for pressure injury, rather than we want to make the patient able to consume the oral fluids and consume the natural way of the GI. For the repositioning, I think the most surprising information, we will have it in the repositioning. Now, repositioning, we are talking about reposition IMG. That means we're talking about compliance and consistency. This is what missed from the previous practice. We're talking about something should be repeated. But when and the time for this repetition? Let's start to see the evidence, how it's already formulated. It's a good practice to reposition individuals at risk of a pressure injury, regardless of the type of pressure redistribution, regardless the type of mattress, regardless the type of devices, regardless of automated bed, hydrotherapy bed. Still, the reposition is the main important human-based intervention. This is clear in the guideline. And the interval between repositioning, and this is the surprising news, since the time maybe of Florence Nightingale, the time for a pressure injury was every 2 hours. the students, they learn it, the people, they learn it from everywhere that we should reposition the patient every 2 hours. Now the new guideline clearly stated that the interval between repositioning might be adjusted depending on the pressure distribution capabilities of the support service, the individual response. However, no support service can entirely replace the repositioning. They said we cannot make it as a one single rule that reposition every 2 hours and then, oh, okay, we do whatever, خلاص, every 2 hours. Rather, they support clinical decision because some patients may be in need for an hourly position. So each 1 hour. And some other patients, they could in need for a reposition every 3 hours. This is depend on the clinical feature of the patient. And that's why there are a lot of evidences about the discomfort the patient will have it from the reposition every 2 hours. The patient cannot sleep even within this time. And there are obese patients that even within 2 hours, the ischemia will happen because of the weight or other comorbidities. So the interval can be adjusted to be every 1 hour, every 2 hours, every 3 hours, or every 4 hours. Depends on the clinical picture and the feature of the patient. R2, it's a good practice to reposition the individual in such a way that optimal offloading of pressure points and maximum redistribution of pressure are achieved. At the beginning, we say that we should put the patient on supine position under specific description for the supine position. But the patients already differ in their own interest, their own clinical conditions, and also in their own preference. The patient maybe don't like to sleep on this way rather than to that way. They say, and they support using of digital matrices that can determine the place of high pressure. And then we will work according to that to reduce the pressure and achieve the patient preferences and achieving clinical objectives. And this is what make the results getting improved. The R3, it's a good practice to use specialized equipment for the repositioning. Now, even if it's still a human-controlled intervention, but the results, and this is a GPS point, found a significant improvement in the pressure injury development when we already adopt the devices that can redistribute this part. It's a good practice, R number 4, to reposition all individual with or at risk for pressure injury using an individualized regimen. And this is the second surprise. At the beginning, while we were practicing in the hospitals, we say, okay, 8 a.m., 10 a.m., reposition time, reminding time, and so on. Now they say this should be planned every morning for the patients under individualized clear regimen. And let's see how the hospitals will do it. But this is the GPS point with a suitable high level of evidence. R5, it's a good practice to determine appropriate and individualized reposition interval based on the comprehensive assessment. So based on what we will determine this time interval for reposition, level of activity and mobility, ability to independently reposition, skin and tissue tolerance, clinical condition. I'm reading in R5, comfort, sleep patterns. What will happen if we just include this in our repositioning decisions to give the patient better time to sleep? Goals of care and support service in use. R6, which is also a good practice statement, it's a good practice to assess for signs of early skin and tissue injury that may mean the individual requires more frequent reposition or preferential positioning of damaged area. And you can see R7, it's a conditional recommendation because it's based on one tier, 1 and 2 and 3A evidence. We suggest that either reposition at 2 hours or 3 hours intervals could be implemented for most individuals at risk for pressure injuries. if they are also on appropriate pressure redistribution full body supporting services. Now, the 2 hours reposition is not the main law. Clearly in the guideline, it can be every 3 hours if the patient's condition already able, or it should be every 1 hour if the patient condition based on the R5 points had been changed. R7, which is a classifier, individualized frequency of reposition based on the clinical assessment as a specific in a good practice segments. You will see R7.2, critically ill individual for or otherwise with a systematic hypotension or shock status may require more frequent repositioning interval. So any patient will be diagnosed as a shock, or the patients in a critical condition ICU and mechanical ventilator. 2 hours is not the best practice now for reposition. We should consider making them with the different protocols to make sure the reposition can be done hourly. Individual R7.3 individuals receiving palliative and end-of-life care should be given the option of reposition frequency interval that are best suited to their goals of care and comfort need, and with the full knowledge of the pressure injury risk incurred with the least frequent repositioning. Now, for the palliative care repositioning frequency, it's a patient decision, not a nurse decision. So the patient should be clear about, or we should explain the risk of the and the patient will choose. He will do it, or he will be needed on hourly, 2 hours, 3 hours, but not more than 4 hours for the palliative. R8, and I think this is also another surprise. We suggest not routinely extending reposition interval to 4, 5, or 6 hours for individual at risk for pressure injuries. So now 5 hours, reposition every 5 hours, 6 hours, 8 hours is not recommended. So the options we have it on less than 1 hour, hourly, every 2 hours, 3 hours, and maximum 4 hours. You can see in the R8.1, progressive extension of the repositioning interval may be appropriate, or some individual based on decreasing pressure injury risk, increased capacity for effective self-repositioning. If the patient able to help in the reposition themselves, so classifier points to add these facilities to the patient. R number 9, it's a good practice to initiate frequent small and increment shifts or micro movements in the body position. So let's make the patient do the muscle contractions if he's able, even without full reposition. And this is in a GPS. So the pressure injury still can be prevented even if the full body did not move or reposition. We suggest using 30-degree lateral position to prevent pressure injury occurrence in the individual at risk for pressure injuries, and this is conditional recommendation to put the patient on semi-Fowler, 30 degrees, and I think this is conditional recommendation because the evidence is also contradicted between the VAB bundle or the ventilator-associated pneumonia and for issues related to pressure injury. Anyway, so you can continue to read this surprising information in the guideline, which is already now available on the websites. I don't want to take a lot of your times while we are talking the points one by one, but now you already get the idea of these differences. Repositioning, I wanted to stress on this one that it's come with a conditional recommendation about using of the sensor system, and there are high strength of the evidence start to be now high about adding a digital sensor or matrix with digital alarming, so this can assist and this has increased the possibilities of proper pressure injury. And R number 16, we suggest that an early mobilization program be implemented in individuals at risk for pressure injury based on the individual's activity tolerance. Also for the SIT, there are also now a special chapter for the preventing pressure injury in the seated individuals. A lot of focus on the wheelchairs, and it's a Clinical practice guidelines, a good practice to consider the following factor when selecting a seat or wheelchair that meets the individual needs of pressure redistribution. Now, the patient could be in paralysis and still working, so he will work in an office, but on wheelchair. So, what are the characteristics of this wheelchair? The individual overall risk of pressure should be taken into consideration. Independency, mobility, and activity needs, body size, shape, weight distribution. There is no wheelchair fit for all. The boundaries of this wheelchair, the nature of a sit where the patient will sit on should have a foam, and this foam should be enough loading, and it's not accepted to have this rubber, plastic, whatever the types of the goal. Again, as we said, there will be a special guideline for preventing heel pressure injuries. Yani now we have a special talking about only heel pressure injury. And remember the statements we were described it before. We said heel never heal, right? So because the heel is challenging. So now we have it under a special section in the guideline. Preventing heel pressure injuries will be posted for stakeholders review in the early of coming March. There will be some updates on it, but now you can download the current version from the websites. What they said, that it's good practice to elevate the heels of individual at risk for pressure injury so the heels are not contact, and this is good practice. Conditional recommendation, we suggest using heel offloading device, and the evidence is now increased to be in a one-tier study about the heel offloading and supporting devices. The H number 3, good practice, the good practice to elevate the heel of the individual at risk for pressure injuries using standard pillow or cushions, if, of course, the H number 2 is not there, which is the specific heel support. It's not recommended now at all. We make no recommendation on whether leave-on topical products should be used to prevent heel pressure injuries. So no need now to use any cream on the heel for the immobilized patient. But we suggest conditional recommendation, H number 5, suggests that preventive dressing could be used as an adjacent to the heel elevation and regular repositioning. So now, no need to add any cream, softener on the heel, because there is no evidence say that this can work. But the heel support, it's highly recommended, could be used the same kind of dressings. Maybe we can use the same 5 layers, which is now recommended on the sacral ulcer to prevent on the heel, but the purpose on this only to offload and support. H number 6, which we suggest that if a preventive dressing is used for the heel, a soft silicone adhesive multi-layered foam dressing should be selected. And this is the only approved dressing for prevention based on the current guideline. We cannot use the hydrocolloid as a prevention, only the 5 layers soft silicone adhesive multi-layered foam dressing, and this is conditional recommendation. That means we have an evidence, but still this is under, we should take it in consideration. Topics and clinical questions under development. What are still the issues that we should take in consideration? Skin assessment, risk-based prevention, planning and implementation. What are the good practice statement? This is what you should be aware about it. Good practice statements, that means this is more supported. Skin tissue assessment, to which extent we can trust in the technology assisted. The studies said that the compliance of the healthcare staff or the way that we are dealing with the Braden is not reflecting why the Braden is important, why the skin assessment is important. So what about adding mandatory technology assisted tools that can adopt the new technologies, adopt the new data management, and provide proper individualized actual assessment about the condition of the patient. Why? Here, when we talk about the Braden, so we are not talking about one tool, rather than we're talking about one of different tools already available internationally for detecting the risk of patient to develop pressure injury, such as Norton, Waterloo, and the MDRBI risk tools, which is specified for the medical device related injuries. But what's already accepted more, it's why we are dealing with this way. It's not only these mistakes, there are a lot of mistakes reported in the evidences, such as missing stage 1 pressure injury in the dark skins. There are confusion can happen between the deep tissue pressure injury with a bruising or contusion or skin beers, and this is why the wound care experts already important in their own hospitals, and why the awareness about what we are talking about is important. There is less recognizing for the medical device related pressure injury because it's not always visible as a wound, and at the same time the people don't think that about the medical device related pressure injuries. There are over relying on the risk scales, but still the clinical judgment of the nurses getting higher, better detachment or correction than the Braden or the other tools. But the studies said that this is not because the Braden is ineffective, but how we fill the Braden or how the healthcare deal with the Braden, this is what makes the problem. So also assessing risk only on admission, not on a regular base. That's why the nurses are, or the admission nurse make the proper skin assessment comparing to the regular assessments not done on the same level. Issues related to assessing pressure injury in the diverse skin tones. This is need also additional efforts for the dark skin, temperature, palpitation, and asking the patient. It's apart from legalization, so preventability and legal documentation. All, as we said, there is no non-avoidable pressure injury anymore. So all pressure injuries now, it's preventable. Why this happened? Why the differences happen between 2019 and 2025? Maybe because of misunderstanding or misleading or misusing this information. All this can be any reasons. Anyway, most stages are coming between 1 and 3, and this is need intervention stage. Some of the stage 4 and then stageable need this or can be under the condition of the unavoidability despite of the best care, but the new guidelines reject that, and they said let's deal with the oil pressure injury as preventable. So even this required changes in the quality indicators and in the criteria of reporting. Documentation should include what was done, when and when, why and when, and risk assessment scores, interventions, and this is the legal protection for the staff that they already dealing with. The evidence paradox, or what we thought versus the reality. Traditional beliefs, as we said, 2 hours turning is enough. Now 2 hours is not the best practice, and this should be done based on the individualized cases. The recommendation about the 2 hours and 3 hours, as we already explained. The golden rule, no surface replace repositioning. And the 30-degree lateral tiled position, evidence-based advances, and this is maximize the sacral offloading, maintain blood flow, lower transcutaneous oxygen loss. No acceptance for the 90-degree position for the patients, and this is all regarding to the repositioning. Now the repositioning take a huge amount on the new guidelines. Whatever they recommend using the technology, but they did not find any evidence that the technology alone can make the repositioning safe. Still should be the human lead. Whatever support we have it for the nurses or the human while they're doing the repositioning is good. No more every 2 hours a golden rule for the repositioning. And this should be individualized based on the patient cases and patient scenario. So the repositioning now, it can be on hourly base, every 2 hours, every 3 hours, and every 4 hours as we described. Braden is still the golden rule for the skin assessment, together with the other tools, but still Braden is the most international accepted. And here we can just quickly here explain the main feature of the Braden. We talk about sensory perception, which means the ability to respond to pressure, skin moisture, exposure to moisture, activity level, movement capacity, mobility, nutritional status, and friction and shear. Here you can see the same for the adult Braden scoring and interpretation. So we talk about less than 11, 12 to 14. It depends on the score. So this is the Braden, how it's already come. It's the same structure. We have perception, sensory perception. So if the patient take 1, that means this is bad. If the patient take 4, this is good. And each specifications for each box, so the patient should match this criteria or this box. So when you come, for example, to say in a patient, we will give this patient 4 on the sensory perception, so the patient should be responding to the verbal commands. In the moisture, and the moisture here for the perineal area. So not the all skin moisture. Braden moisture did not discuss all the moisture of the skin. Other than that, in the skincare lecture, we know that the good moisture is something good for the skin. But talking about here the perineal area, and this should not be moist or rarely to be moist. Activities, bed fast, chair fast. So when I give the patient walks frequently, that means the patient able to change and walk out of the bed every 2 hours in a waking time, not on the sleep time. The same mobility. So here let's take them one by one for clarification. The sensory perception, it's a 4 points. Number 1, no response to pain, non-responsive, the patient will take 1. The patient will take 2 if he responds to pain only. Score number 3 or score level 3, response to verbal commands only. 4, response to all stimuli. Skin moisture, again, we're talking here about specific area, and we are measuring the incontinency. So if the patient able to go to the bathroom by his own and there is no incontinency, the patient will take 4. There are diaper, or sometimes the incontinency happens, so stage or score will be 3. Score 2, the skin moist often, which means that within the interval of 8 hours. So within the 8 hours, there are perspiration or incontinency happen. So this score will be 2. In the duration of less than the 8 hour, this happened more than 1 time, that means skin almost always wet. And this is now the rules for applying the Braden. The activity level, score 4, walks frequently. Score 3, walks occasionally. Score 2, confined to bed but can change position independently. Score 1, confined to bed and cannot change his position, such as sedated or an ICU patient. And the same for the mobility, and now for the nutritional status and friction and shear, as already explained for you. Now, mistakes in the Braden, confusing between activity and mobility, and they are different. So this is what already we see the evidence stress on it. Activity different than mobility, and the practicing staff should be able to differentiate these differences. Scoring sedated patient as anything but 1 on sensory perception, this is wrong. If the patient was sedated, so in the sensory perception will be always 1. Forgetting that the nutrition score reflects actual intake, not potential, and overlying on a score without clinical judgment. The studies say the clinical judgment of the nurses better than the same nurse when they apply the Braden, as the same reason what we discussed. Score is guidance. It's a legal document, and it will guide you for what you should do. And also for the Braden Q scale specifications regarding to the Braden Q, and the one who developed Braden Q, who was a student of the Dr. Braden, Al Braden. So they just only make additional points specific for the childs. And now in the guidelines, the childs from 1 to 18, not from 1 to 16 as it was before for pediatric physiology differences. Different mobility activity patterns in the children, high metabolic rates and recovery, different nutritional assessment markers and modified scoring range. Now here, and this is important for you to notice, that in our region, in our hospitals, maybe in the years of 12, we will transfer the patient to adult, or 14. So make this in consideration while we are adopting the new guidelines in how we will adopt the Braden Q. Anyway, in the Braden Q, they already add the total score range, the risk cut-off, activity, mobility, and nutrition, and the oxygen. So this is why it's already getting little bit differences, because they assume that the patients in less than 18s, they in need for higher metabolic rate, so they have faster tissue turnover, but also faster growth of injuries. So this is why the patient in this pediatric can get the wounds to heal faster, but on the same time get higher chance to develop to the pressure injury, because tenor of the derms, different pressure points, mainly for the pediatric ICU and the neonatal ICU, and the CPAP mask, endotracheal tube feeding, and the kind of devices that we are using with it. Neonatal pressure injuries, there are a lot of challenges faced the neonatal ICU and the people who are working on the neonatal cases. The incidence of the pressure injury in the neonatal ICU getting higher internationally. Medical devices related, and it's not related to the same problem on the adult, so that the repositioning is not the same concern in the neonatal ICU, but on the same time, the pressure injury increased the prevalence of the neonatal ICU and the pediatric ICU, and mainly it's associated with the devices they use, skin differences, and assessment challenges, because we cannot adopt the same strategies of thinking in the pressure injury prevention for the pediatric and neonates. Anyway, there are talking about the specification for a neonatal Braden Q, and this add the oxygen as a main indicator for the risks for pressure injury development. Medications such as the vasopressors and sedatives also on the pediatric can add more risk. The Braden Q for the neonatal says less sensitivity comparing to the other and specificity, and this is need additional research and using, and they rely here on the updates on the Braden recommendations for NI Braden Q preferred for neonatal ICU from the last year. Neonatal ICU, the medical device related pressure injury is the most common. Nasal bridge, cheeks, feet, and abdomen, all this the common sites. The prevention, again, the frequency of assessment should be different. Usually in the adult, the assessment will be done for the patient every 8 hours or when the nurse start the shift. But in the neonatal, there is need to do inside the shift 2 times until we evaluate the condition. Now, the reposition could fail, the compliance crisis, as we said, staff shortage. This all means more workload, but this is required. The repositioning should not be failed even with these changes. Now, the level of control could be different. At the beginning, there was reminding, there was some follow-up that we should see all the patients on 10 a.m. on right position, then all of them on the... Now, this will not be the same based on the new guideline and recommendation. So we should not have a staff shortage, and they have a direct connection between staff shortage and the development or high rate of the pressure injury. So the units with the staff shortage complain of higher pressure injury, then the patient suffering more, then this patient go to the court and make sue on the hospital, then they get reward. So at the end, the hospital did not save money from not recruiting the staff. Workload, knowledge gap, patient discomfort, and medical instability. So we need more visual reminders. Maybe apps now can be applied for the patient, or connecting the electronic health records with the patient, with the nurse mobile, or whatever the kinds of the visual reminders, technologies, empowerment, flexibility, and interdisciplinary supporting works together. Anyway, I leave here for you some cases about how we can apply the Braden and so on. Anyway, The documentation is important for the Braden score, for the date and time that already assist, increase the legalization of the pressure injury prevention strategies. And we need also to have the communication with the team and offering they said here about the referral system, which could be like in a wound care, or the quality people, or the responsible staff about inform of patient in risk for pressure injury even before they developed the ulcer. And there are some recommendations. Anyway, here for the action principles, 2025 guideline, we're talking about variation in the 2 hours. So it's not rigid 2 hours, it can be 1 hour, 2 hour, or 3 hours. Lateral 30, better than 90 on the reposition, on the lateral position. Braden scale is the trigger tool, but it's not a diagnostic. Pediatric Braden Q and the neonatal Braden Q requires adapting scoring. Compliance requires system thinking. It's not just a protocol to apply. So we are not robot, and we need to have more in our parts. At the end, today we discuss about the terminology shift, pathophysiology, classification, risk assessment, and we start to introduce the new guideline. And this is what we need here to focus on it more. It's about from grasping these differences, staging, diagnosing, and treatment. And this is what we don't want to see. This is a pressure injury. This is in this case, this is combined incontinence associated dermatitis, and this is not a pressure injury. So you can see here the differences, and then the incontinence associated dermatitis will have additional discussion. But this ulcer, that what you are seeing now, it did not develop because of ulcer. It developed from the moisture. So there are differences in this one. This is not a pressure injury. This is fungal infection. This is irritation. This is eczema. This is something not related to the ulcer. So this is what we should be careful while we are describing. This is also not an ulcer. This is incontinence. This did not develop due to the ulcer. So this is what the skills that we should take into consideration. This is pressure injury. This is unstageable occipital pressure injury happens. So this is why we should be critical in defining the meaning of the pressure injury, critical in reporting, critical in preventing, and assuring that this can be avoided if the current guidelines already take in consideration. We don't want to reach a stage like this one when we have stage 4 pressure injury that exposed in bone, exposed in the muscles, internal organs, and you can see these bubbles, which is all referred to the biofilm, and deformities happen. This is also stage 4 pressure injury. We have exposed for the bone, exposed for the internal organs, and this means deterioration happen on the cases. Anyway, one of the traditional practices, this is one of our patients, and when I visit him at home, the family were putting coffee inside the wound. So I don't know why they are using the coffee here. Is it about from the practice? Anyway, they complicate, and of course the coffee is make the situation worse, because simply the coffee is a base material, and the bacteria need the space. So we are destroying, and we're making so much effect. Anyway, this is a pressure injury happen, and this is what we don't want. Well, this is what we should fight and take it in consideration. So thank you very much. Inshallah, also in the coming part from this module, we will continue with the assessment, surveillance, and the prevalence of the pressure injury, and some also important tips for the practitioners. But here in today's lecture, we were focusing more on the definition, staging, and what are the key points of differences. I think this is just updated information. We're talking about the final agreement happened on this guideline, happened before 2 weeks, and still the updated will coming on. But now we have all the chapters of the guidelines already open. If you're following up since February, there are some links is not working because they did not approve or make the final approval. Now all the links already approval, and they mentioned that maybe any modification will be added based on the relevances. But finally now the new guideline already in our hands, and this is a good starting point for all practitioners to use it and to understand and grasp what are the differences happen on this guideline. Is there any question or concern؟ في أي سؤال أو استفسار؟ الله يعطيكم العافية يا ربي، وشكرا جزيلا لكم. سبحانك اللهم وبحمدك، أشهد أن لا إله إلا أنت، أستغفرك وأتوب إليك. نستودعكم الله الذي لا تضيع ودائعه، ونراكم إن شاء الله في لقائنا القادم. Thank you very much and see you إن شاء الله next week. This is Dr. عبد الكريم. السلام عليكم ورحمة الله.
Recording stopped.